Okay, welcome to week 3. This is the last installment on the on blood, the hemat. Wow, I can't even think straight here. But let me see. Let's change my ink color so I can scribble all over the screen. Anyway, next week we start into immunology. Immunology is a personal favorite of mine, and during COVID-19, it will probably be something very important that you will need to know. And we'll talk all about that when we get to immunology in the final weeks of this course. So we've talked about what red blood cells are, how red blood cells are put together. Now we're going to talk about what happens when it goes wrong. And anytime you have less than stellar red blood cells in your body, we call it anemia. Now, a lot of people get confused because they see anemia as a disease. It's not really a disease. It's more of a description or more of a symptom. For example, if you have sickle cell anemia, sickle cell is the disease. The anemia part of it is just saying that you're low on red blood cells or your red blood cells aren't working right. So anemia is more of a category than it is actually a disease. And there are several different types of anemia. And we're going to hit on a couple of them. We're not going to hit on all of them. Remember this guy? You see him, you might see it on a test. We're working with concepts. The concept-based curriculum doesn't fit real well into this as well as it does with other things, but we still have to include it anyway. It's part of the curriculum. But cellular regulation. But there are other concepts that fit into anemia as well. For example, oxygenation. That's a big one. If you're not getting all the red blood cells you need, or the red blood cells aren't doing their job, you are not oxygenating your body. In fact, I would be more inclined to say that concept of oxygenation is probably more applicable here. We're going to discuss different ways of detecting anemia, although most of you probably already know that, and how we care for the anemia patient. Now, the reason I put cellular regulation on here, and I need to extend that underline a little further, is it talks about the growth and replication of cells. And here we're talking about red blood cells, the manufacture of them, how they manifest. Sometimes it's good, sometimes it's bad, and how they are destroyed. And by understanding this process, it'll help you understand the anemia patient better. So, what is anemia? An abnormality within the human circulatory system that results in low RBCs or high hematocrit concentration. There again, as we're looking at this point here, anemia results in reduced oxygenation to the body because it's the red blood cells that carry the oxygen, and there are a variety of causes. I do want to point out, and I don't have the slide in here. I meant to put it in, but I didn't. I forgot. But anyway, there's basically 3 kinds of anemia, and you might have gathered this when you read the article for your assignment this week. There's a case where you don't have enough red blood cells, and that happens, for example, if you're in a car accident and you're bleeding. Or if you're internally bleeding, you don't have enough red blood cells to carry the oxygen around in your body. So that's one type of anemia where you're losing red blood cells. A second type is you're destroying them faster than you can manufacture them. So let's take the case of a kidney patient. With a kidney patient, he's not producing the erythropoietin to go to the bone marrow and produce it. And if you remember, it's about 2 million red blood cells a second are being destroyed by the human body. They've done their 120 days, they're done. If you're not producing 2 million red blood cells a second, then you're going to develop a deficit. And that's what happens in kidney patients because they're not manufacturing 2 million red blood cells a second. And the third type of anemia is when there's something wrong with the red blood cells themselves, where they're not doing their job. Sickle cell anemia is a very good example of that. You're getting the red blood cells, they're being manufactured. You have the number you're supposed to have, but the red blood cell, there's a problem with its shape, so it's not doing its job. And we'll look at sickle cell here further down. So there's basically 3 ways to get anemia. You're either losing the blood, you're not manufacturing it fast enough, or the blood you got is not doing what it's supposed to do. And I think if you put those 3 categories in your head, it kind of simplifies it a little bit when we start talking about the different types of anemia. How do we know if someone has anemia? Well, there's some risk factors. And of course, trauma is one of those. Don't get in a car accident. Don't shoot people. Anything like that that will cause you to lose blood. Pretty much any Jason Statham movie you see, you will see that type of anemia. Menorrhagia, the period, females lose. I probably mispronounced the hell out of that, but women lose a lot of blood during that period. GI bleeds, post-surgical bleeding, any place where you're going to lose blood. And you probably know by now, if you have internal bleeding, the blood goes through the stomach, and we'll talk more about this when we get to GI. Or I should say Eileen will talk more about this when she gets to GI. If you have blood going, if you're losing blood in your stomach or in your intestines and it goes through your intestines, your body digests it. And that's why your stools come out black and tarry. So black and tarry stools will mean that the bleed is high up in your GI tract. If it's lower, if it's in your large bowel or your hemorrhoids, the blood has not been digested. The blood will come out red. So that's just something to put in the back of the mind. And that you'll cover more of that when you get to GI. But if somebody has black tarry stools, they could have a GI bleed or a stomach bleed. Well, GI covers stomach and intestines. Increased hemolysis, defective red blood cells. Like I said, this is one where you've got the red blood cells, but they're not doing what they're supposed to do. Or something is destroying the red blood cells. Let's say a transfusion reaction. You give type A blood to a type B person. Your immune system is going to attack that blood and start destroying it. So you're actually killing off your red blood cells. And that's not a good thing. And then here again is inadequate diet is another risk. And this is the big one right here. That's why I underline it. This is a really big one here. Iron deficiency, B12 deficiency, folic acid deficiency. These are very common in senior citizens who are not eating the way they should be eating. If someone's on a diet that's particularly deficient in iron or deficient in B12, they could be having problems. They say a lot of times that vegetarians should take a vitamin B12 supplement because a lot of the B12 is very common in meat, but it's a lot less common in other food products. So just to be on the safe side, if you're going to be vegetarian, yeah, you may want to take a B12 supplement. So there we go. Any questions on that before I go any further?
Yeah, I have a question.
Okay.
When I was looking at the assignment on the 3 types of anemia, I could see the article says of microcytic, macrocytic, and nomocytic. But from the way you are trying to describe the types, I'm just wondering where would I classify something like sickle cell anemia?
Okay, I'd have to look closer at the article, but yeah, they're talking about microcytic, meaning small, macrocytic meaning too big, and normocytic meaning exactly what it should be. I think
Mhm.
that would fall under the category of you've got the right number of blood cells, but they're not what they should be. In other words, thalassemia, where the blood cell is I think it's too big. I have to go back and look at that again. But in the case of sickle cell, the cell is shaped wrong. So that's the category that was talking about in there. Does that make sense?
Yeah.
Okay.
Okay.
I'll go back and look at it and give you a clearer answer on that.
Yeah, I also found the same thing while I was looking for the different kinds of anemia. In the article, it says what the Jackie said right now.
And they talk about, yeah, I remember that. I remember that in the article. I'm trying to think, I got the article right here. I'm trying to think of in what reference they were using that. Let me take a quick look and see if I can find it. Okay, I see the microcytic. Yeah, they're using the example of iron deficient anemia and thalassemia for microcytic. But yeah, the characteristic of the thalassemia is that the red blood cell is too small. Now, if you go back and you look at the CBC and you remember we had those weird tests called MCV and MCH. The MCV test was mean corpuscular volume. And what that was saying is how big is the red blood cell? Because you remember the blood cell has to be the red blood cell has to be a certain size so you can have all those hemoglobins on it for the oxygen to attach to. If the red blood cell is too small, you can't have as many hemoglobins on the red blood cell, and you're reducing the capacity of that red blood cell to carry oxygen. So in the case of thalassemia, the smaller red blood cells mean that your red blood cells are carrying less oxygen per cell, so your body's getting less oxygen. Macrocytic means that the red blood cell is too big. And I'm trying to think of which one that was, but I'll go back and I'll look at it and I'll let you know. But yeah, the macrocytic, microcytic, and normocytic is talking about how large the red blood cell is. So those would fall into the category of you've got the right number of blood cells, but they're not doing what they're supposed to do. It's not like trauma where you don't have enough blood, or like kidney failure where you're not manufacturing enough red blood cells. That makes sense?
Okay, so does it mean sickle cell is under microcytic?
I believe so.
Okay.
And the three categories that I was talking about, that's not the same as microcytic, macrocytic, normocytic. That's a separate issue. I'm talking about three ways you can develop anemia. And that's by losing blood, by not producing enough blood, or by your red blood cells not doing what they're supposed to do. That make sense?
No.
Uh-oh.
That is from the assignment.
Yes, yes.
What are we answering? The one you're talking about or the one that is in the article?
No, I'm not. I'm not going to ask you about microcytic, macrocytic, or normocytic. That was in the article.
Okay.
Well, whether I'm addressing microcytic or macrocytic depends on which deficiency I'm talking about.
Okay.
Because some of them, like, yeah, the sickle cell I would put under microcytic. The thalassemia I would put under microcytic. I'm not sure what the macrocytic were. I'd have to look at that. Don't get too hung up on the macrocytic and microcytic though.
That's okay.
Here's some other risk factors. And there again, the same way that the kidney failure can prevent you from manufacturing an adequate number of red blood cells, so can chemotherapy or certain types of cancer. Aplastic anemia is a cancer in the bone. And so if you have something attacking the red bone marrow, whether it be cancer, whether it be radiation, whether it be chemotherapy, anybody that's killing off the capacity of that red bone marrow to manufacture red blood cells is going to result in anemia, because of course you're not going to be manufacturing the number of red blood cells you need to. So that's why very common cancer patients look extremely anemic, if you ever see them. Age is a factor. Like I was saying, senior citizens don't always eat the best diet for a variety of reasons. You know, they may have disabilities that prevent them from cooking for themselves, or just your taste buds kind of go south as you get older too, and a lot of stuff starts tasting the same. So you may not be have the best diet, and for a lot of them it's just financial. They just don't have the money to, you know, go out to nice dinners or buy the best food. Gastrointestinal bleeding, I already talked to you about that. Here's an example of, or this is what sickle cell looks like. This is a cross section of the normal red blood cell. You can see it looks like a little candy. It's got a big indentation there. The reason that indentation is there is that provides more surface area for the hemoglobin to attach to. The more surface area, the better. That's why this red blood cell is a miracle of engineering. And then all these hemoglobin collect oxygen so that this little red blood cell can run around and hand that oxygen out to everybody. Sickle cell is a genetically inherited disease. It is a recessive genetic disease, meaning if you have a parent that's not sickle cell and a parent that is sickle cell, the non-sickle cells genes will dominate and the child will not have sickle cell. The only time you can have a child that has sickle cell is if both the mother and the father have the gene and the child inherits both recessive genes. It is characteristic of African Americans only. They are the ones who carry the sickle cell gene. So this is strictly an African American disease. And the reason they call it sickle cell is because it looks like a sickle. That's what the red blood cell looks like. Gets deformed. Not only is it not carrying oxygen properly, but because of its weird shape, it plugs up blood vessels and it clots the veins. And this is extremely, extremely painful. I have had a couple sickle cell patients, and I'll give them 5-10 milligrams of morphine, and it doesn't touch the pain. If you do get these patients in, don't hesitate to use large dosages of pain medicine because they are used to it. I mean, it is extremely, extremely painful. There's a lot of pain in your periphery, in your capillaries. It's really an awful disease. But that is an example of deformed red blood cells. What you might see in a person, you're going to see pallor. You're going to see that whitish, pale skin. I'm sure many of you have probably seen people with anemia. They get this kind of real pale, and that's because the red blood cells are not getting to the surface of the skin, and that's what makes your skin nice and pink. Of course, they're not getting the oxygen they need, so they're going to be a lot of fatigue. One thing that's not in here, but I do notice in a lot of anemic patients, is they lose a lot of weight. They're usually very slim, very skinny. You'll get numbness in the extremities. There again, that's because the blood is not getting the oxygen to the tissue. You can get some irritability, as anybody who's not getting enough oxygen will get that way. Dyspnea on exertion. Sometimes anemia can be very, very subtle. I mean, it's a very slow, gradual process. And this may be one of the first manifestations, is a person saying, man, I used to be able to run up those stairs. Now I get to the top of the stairs and I'm exhausted. You know, he goes to the doctor. One of the things the doctor may check for is anemia. And sensitive to cold, because your blood is not getting to your periphery as efficiently as it should. They'll usually have like real cold hands, real cold feet. These are a couple of things to look for. You see any of these kind of signs here, especially in older people, I'd have a little red flag go up in my head saying, yeah, they might be anemic. Iron deficient and folic acid anemia seems to be really common in older people. Physical findings, we kind of went over that. Now the tachycardia and the dizziness, well, the heart's trying to compensate. You know, if the body's not getting enough oxygen, the heart will speed up to try to get more blood to the tissue, hoping that solves the problem. Sometimes it does, sometimes it doesn't. Now, one thing that's unique about vitamin B12 deficiency is it can cause a very red and smooth tongue. It kind of swells, it kind of gets reddish, and numbness in the hands and feet. Moving on. So how do we find this anemia? Any questions before I go into the labs? Oh, here's where I'm going to talk a lot about, you know, how we can, how these different tests will help you figure out what type of anemia they have. Well, the most obvious test, of course, is the complete blood count, because that's what measures your red blood cells. Or a high hematocrit could be indicative of low red blood cells, because that's the ratio of red blood cells to everything else in your blood. This RBC are actually the hemoglobin test is kind of the first thing that we look at. And, you know, when somebody's hemoglobin starts to get down to 8 and 7, that is severe, severe anemia. And that's when I'm talking to the doctor and saying, do we need to do a transfusion on this person? Because their hemoglobin is really low. So other indicators are, and we talked about these in the other labs, the mean corpuscular volume. V means volume. And mean corpuscular hemoglobin. This is the number of those little hemoglobin molecules that are on the red blood cells. This one is used for a couple things, but we don't look at that a whole lot. And I will show you how each of these relates to each of the different types of anemia. Iron study, if somebody has iron deficient anemia, of course, you're going to do an iron test. Pretty black and white there. Some other tests that are more rare, and this is when we start suspecting something different. The hemoglobin electrophoresis, they go in the lab and they separate the hemoglobin into the different types. Now there again, this is good for thalassemia and sickle cell, because we can see, you know, exactly what those red blood cells look like. Are they too small? Are they shaped like a sickle? And that will tell us what type of anemia the person has. There's also a test specifically for sickle cell. And there is a test specifically for vitamin B12 deficiency. Now, that being said, there's two ways you can be deficient in vitamin B12. Either you're not getting enough of it, or you're having trouble absorbing it, which is called a B12 malabsorption deficiency. And if we're looking for cancer, we do a bone marrow aspiration. which we talked about in week 1. How do we take care of the patient? Any question on the labs before we move on?
Yes, I have a question. So for vitamin B12, do you check the blood or the serum?
Yes, yeah, you do a CBC, or well, what you might find is a deficiency in the red blood cells when you do the CBC. And if the doctor suspects that it might be, and I'm trying to remember which one it was, but I have a chart. I don't know if the chart's in here or not. I'll have to put that chart up online. But I think it's the MCH. If you look in your ATI book, there is a chart, figure number 35.2, and it kind of lets you know which tests tell you which anemia is what. For example, an increased MCH may indicate a vitamin B12 deficiency. I wanted to get that chart and put it online, but they didn't have it available. So that's the nice thing about the other textbook we have, is you can download the diagrams. We can't do that with ATI. Now, I'm not going to ask you which one of these detects which anemia. I mean, if you're curious, you can look that up, but I think that's a little bit more detailed than we need to go into.
Okay, thank you.
But just bear in mind that we look at the MCV and the MCH to help us diagnose which type of anemia the person has. I know thalassemia, we look at the MCV for thalassemia. And I think we look at the MCHC for sickle cell. I'm not sure. I'd have to look that up. There's a whole, I just refer to the chart when I have to know. Now, how do we care for the patient with anemia? Well, considering there's 3 different vitamin deficiency or vitamin or mineral deficiencies, diet is a big key. They can be vitamin B12 deficient, they can be folic acid deficient, or they can be iron deficient. And all of these can be supplemented by diet. I know a lot of people are, point the finger at vegetarianism. They say, well, all vegetarians are anemic because they're not getting the iron or they're not getting the B12 they should get. And I've seen that before. I've seen vegetarians that look very pale. And I'm thinking, wow, you really need to modify your diet. You can get those vitamins in the diet. You just have to be very careful to make sure you're buying the foods. I mean, you can't just eat lettuce and carrots. That's not going to do it. So diet is very important. Monitoring oxygen levels. If they are not getting the oxygen they need, that will show up on your pulse ox when you do the pulse ox on the finger. And you want to administer and educate the patient on the medications. Now, a lot of times this will be nothing more than vitamin supplements. They'll be getting a folic acid supplement. They'll be getting an iron supplement. They'll be getting a B12 supplement. Some of the things you might want to tell them, I don't know if I got it in here or not. Yeah, okay, I do talk about the different medications, so I won't hit that right now. But there's certain medications do certain things, like iron will make your stools darker. And so people will think they have a GI bleed because your stools are coming out black. And it's like, no, you're on an iron supplement. So there's some things you need to let the patients know. So let's take a look at those. Iron deficient anemia, they'll probably be taking an iron supplement. It can be oral or parenteral. In other words, we give them a shot for it. About every 4 to 6 weeks, they should have their hemoglobin checked. There again, like I said before, hemoglobin is the best indicator of somebody having anemia. If they're taking an iron supplement, they might want to take a C vitamin with it, or vitamin C tablet with it, because it helps the iron to absorb into the body. And here again, as I was just saying, their stools may come out not necessarily black, but darker. So a lot of people on iron supplements might get a little worried thinking, oh my God, I got a GI bleed because their stools are black. Unless they're actually having intestinal pain or problems, I wouldn't worry too much about it. It's probably just the iron that's making the stools darker. Folic acid is one of the B vitamins. If you go out and you buy a vitamin B complex, you'll have B1, B2, B12, B6, and folic acid. So it's in the vitamin B category. And there again, it can be taken as oral or it can be a shot. It may make your urine, I think the B12 makes it bright yellow, I believe. We oftentimes, when we had one of the, and I'll just do this as an aside note, one of the people that suffer a lot from anemia are alcoholics because of their alcoholism and because they're messing with their liver, which is responsible for a lot of the vitamins going into their body. They will usually be they will have a deficit of vitamin B12 and folic acid. So usually when a patient with severe alcoholism comes in for whatever cause, could be alcohol poisoning, cirrhosis of the liver, whatever, we will sometimes give them what's called a banana bag. And a banana bag is a bag of normal saline into which we inject a whole bunch of vitamins to try to reinforce their system and make up for the deficit. Plus the fact that alcoholics don't eat right. You know, they'd rather drink than eat. Folic acid and B12 are one of the vitamins we put in the bag, and they're bright yellow. So it makes the bag look bright yellow, which is why we call it a banana bag. But you may run into those sometimes. If somebody mentions a banana bag, that's what they're talking about. Oop. Vitamin B12 supplement. Okay, this always throws my students when we're in clinicals because it may be listed as cyanocobalamin. And they look at that and go, what the heck is cyanocobalamin? It's B12. So more than one student has to look that up once in a while going, what? The B12 does help convert the folic acid in the body. So along with vitamin C, B12 helps with the folic acid. It can be oral, it can be a shot. It can be a little irritating into the tissue. So the deeper you can get it into the tissue, the less irritation that you will likely have at the site. They usually get an injection once a month, and B12 helps dramatically with hangovers. So now it's really popular for people in Vegas to go to a local clinic and get a vitamin B12 shot and a liter of saline for their hangover. I figure if you got to do that for your hangover, you need to drink less. There are some specialized medications like hydroxyurea is used for sickle cell. And what we're trying to do is encourage more red blood cell production, hoping that to get more normal blood cells to dilute the sickle cells. That makes sense. And of course, for significant blood loss, like you're in a car accident, we just use a transfusion. Give you some red blood, some blood. Anybody have any questions on the blood typing? Does everybody understand how that works? No questions on that? Okay. Time. Okay, finishing up here. The only or the most serious complication of people with anemia is, remember we had tachycardia there. You're going to make the heart work harder because the poor oxygenation of the blood, the heart tries to compensate by working harder. I mean, this is especially true of kidney failure patients. If you're not getting enough oxygen to your body, one of your body's first reactions is to increase your heart rate, increase your blood pressure, so that your body is pushing the blood faster and harder into your body. Now, if you have thalassemia or some other anemia that your blood cells are not operating properly, it's not going to fix the problem. It works well, and this is nature's adaptation to trauma. You know, I'm out and a lion bites my leg and I'm bleeding and I'm starting to lose consciousness. My heart will speed up to try and get more blood to my brain to keep me conscious. That's the body's natural reaction to poor oxygenation. But depending on what's going on, what kind of anemia you have, it may help the situation, it may not. But whether it does or not, your heart is working harder, and that can lead to congestive heart failure and to heart failure itself, because your heart is just getting stretched out of shape because it's working so hard. Congestive heart failure is also very common in people with high blood pressure and smokers, COPD. They're making their heart work too hard, and that usually ends up with congestive heart failure. Some things you can do: monitor oxygenation to keep an eye on their oxygenation status. We may need to give them supplemental oxygen if their body's not getting enough oxygen. So we can just try to overload what red blood cells they do have that are working. We can try to load them up with oxygen. Another one is monitoring cardiac rhythm. This again will show if their heart is overworking. You begin to see variations in the ECG when they start to get cardiomyopathy. Daily weight. Like I said, a lot of people I've seen that are anemic, they lose weight rather rapidly. And just be sure they take their medications. Any questions? This one's short and sweet. Anemia is pretty straightforward. It's your red blood cells are not getting the oxygen to your body the way they should. No questions? Ta-da! That's all I've got for you. And this will finish up our hematology section of the class, and we will move on to immunology next week. Any questions before we leave this presentation?
Nope.
Nope. Okay, clear as mud, right?
I have a couple questions, but not from that content.
Okay, then I'll stop the recording now.